Hello, good morning. Today I'm going to be presenting the ground rounds on the case of Elena M. So, Elena M is a 42-year-old female with a history of stage 3B breast cancer. She completed anthracycline-based chemotherapy with doxorubicin, otherwise known as the Red Devil, 8 months ago, and is currently in remission. She's presenting now with bilateral lower extremity swelling and progressive fatigue. No prior cardiac history, no known structural heart disease. Um, this is going to prompt further evaluation. She's relatively young, and this is a strange, somewhat cardiac-looking presentation. So what's she on? Right now, she's taking tamoxifen, 20 milligrams PO daily for cancer prevention. She has an estradiol or Zofran, 8 milligrams as needed for nausea. She's also been taking ibuprofen, 600 milligrams daily for pain. Um, Importantly, she has a clinically significant history of anthracycline exposure. So she took a lot of doxorubicin, kind of the upper range recommended for her body size. Do we have any concerns immediately looking at this medication list? Maybe, maybe not. We have swelling, which could indicate kidney, but so maybe not the ibuprofen, but so far this is a pretty small medication list. All right. So we do a quick review of systems. She's mildly tachycardic with her vitals being BP 108 over 68, heart rate 110, respiratory rate 16. She's 91% on room air. Um, she got 2+ pitting edema on her ankles. Um, Fatigue, decreased urine output. Her lungs are clear on auscultation. Now, that's a surprising finding. At this point, we would be expecting some pulmonary edema, some backup into those lungs with this edema in the lower extremities. So, right now, she is compensating at least a little bit, but the renal system is really what's calling to me, as is the cardiac system. Let's take a look at her labs. So, BMP 880, sodium 129, creatinine 1.6 from a baseline of zero point 0.9, BUN of 25 milligrams, and a lightly mild troponin. So, how do we interpret these? That BMP is telling us there's some ventricular stretch. Her heart is under volume or pressure stretch. Um, the sodium suggests a little bit of dilutional hyponatremia. So she's retaining fluid. Creatinine tells us renal perfusion is decreasing. And again, we're looking at the RAS system with that BUN level. The troponin's a little bit elevated, and that tells us that there's probably ongoing myocardial strain, probably not an acute infarction, but do we want to run an EKG anyways? Sure. Clinically, probably a lot of us would, just as a covering all our bases thing. Now, these labs aren't necessarily indicating a acute myocardial infarction, but it's never a bad idea with some cardiac signs and symptoms and some mildly elevated troponin to run that EKG. Let's say we ran it and it was normal. Now we go in on a cardiovascular exam. Her ejection fraction is less than 40%. She's got left ventricular dilation, reduced systolic function, and mild global hypokinesis. So she's got her heart starting to fail. Why does that happen, pathophysiology? Well, the doxorubicin, the anthracycline that she was received for her chemotherapy, caused stress to her cells, which caused mitochondrial damage, which caused the heart cells to die, which is reduced contractility, which is decreased stroke volume. Um, so her heart cells have been badly wounded by the doxorubicin and have died, and now her stroke volume is decreasing, which in turn is causing an activation of RAS, which in turn is causing her edema and heart failure. So here we are. Reduced cardiac output, as I said, is activating RAS, which tells the kidneys to retain sodium water, which increases the preload of the heart, which in turn causes peripheral edema. And now we have a cardiorenal syndrome. So she's backing up. Now, we often expect like dyspnea, orthopnea, crackles on exam with fluid volume overload, but her lungs are clear, so she's probably early decompensated. So she's still trying to compensate. And pulmonary congestion is not yet clinically prominent. So this reinforces that what we really need to be doing is finding these subtle symptoms, especially in people with histories of these pretty, rough drugs, before they decompensate fully. So how are we going to manage her pharmacologically? Well, we have a few different options. Um, Remember, we also want to improve her quality of life, not just her quantity of life. So to block RAS, ACE inhibitors are typically first line, often well tolerated. So we can interrupt that cascade early and reduce fluid retention. Um, we can use a beta blocker carefully to blunt that nervous system reaction that might cause her to bottom out on her blood pressure, though, with that borderline soft blood pressure. So I would be very careful about that. We could reduce volume with a loop diuretic, but we'd have to monitor her labs carefully given the risk of hypokalemia. And then we should stop that NSAID immediately. We don't want to stress that kidney more than we already are stressing her kidneys. Um, And then again, we have to talk about her quality of life. She's reporting generalized pain, which is why she's taking ibuprofen. We should probably look into that, refer her out to her pain specialist, send her back to oncology. Something's going on there, but we don't have time for it today. Today, we're talking about her heart. So, what are our clinical reasoning questions? Why is she hyponatremic despite fluid volume overload? Why is her creatinine rising in the absence of intrinsic renal disease? Why must beta blockers be introduced cautiously? I kind of gave you the answer to that one already. And then how did the doxorubicin or anthracycline therapy contribute to this presentation? Um, so these are the questions I want you to be thinking about. Let's bring it all together. Anthracycline cardiotoxicity can present months later. Heart failure with reduced ejection fraction can present without pulmonary symptoms initially. Hyponatremia suggests advanced neurohormonal activation, and early recognition prevents progression. Again, this is a 40-year-old. She's young. If we catch this now and we treat it and stabilize her, she could have a lot of life ahead of her, a lot of good life ahead of her, not just life, but good, meaningful, active life ahead of her. So again, I wanted to present this case study just as a unusual presentation of heart failure in a 40-year-old relatively young woman with a history of breast cancer. And I wanted to present it because I wanted to emphasize that we can improve quality of life for young, relatively okay. I wouldn't say she's healthy, but I'd say she's relatively all right given her medical history people. And as nurses, that should always be our top priority. Here's my reference list in case anybody wants to read any of the papers I've referenced or the procedures. Thank you so much for your time. I really do appreciate it.